Okay. Assalamualaikum warahmatullahi ta'ala wabarakatuh. So we are from group 4 and today we will be presenting on honor syndrome. Next. Before we start, let me introduce myself. My name is Fatimah Nazira binti Muhammad Zuki and my group members are Nur Syafiqah binti Syamsuddin, Nur Anis Mardiah bin Muhammad Nazri, Badi Uzaman bin Aziz and Nur Hayati bin Muhammad Nur. Next. Okay, let us look at the table of contents. So firstly, we will discuss on the case summary. Next is tentative diagnosis, final diagnosis, and the definition of the honor syndrome, prevalence. Next. Etiology, pathophysiology, sign and symptom, clinical examination, and management, and also conclusion for this presentation. Next. Okay, firstly, let us go to the case summary and I will be the first presenter and my name is Fatimah Nazira. So next, let us go to the patient information. Basically, this patient is 45 years old male. He is Malay and his occupation is a lorry driver and his hobby is playing checkers or also known as Dam Haji. Next. Okay, let us look at the patient's complaint. So firstly, this patient complained of difficulty in night vision on right eye, especially during driving. And he needs to close his right eye while driving at night, and this lead to the complaint of headache during driving at night. He also complained of sudden mild droopy eyelid on the right eye since 3 months ago, and this caused difficulty on the upper visual field and needs to elevate his head to look up. And lastly, he reported of reduced sweating, especially on the right side on the same duration. Next. As for the ocular and prescription history, he is currently wearing multifocal and this spectacle was made since 1 year ago. And for the past medical history, he has been diagnosed with the pancreas tumor since 6 months ago and has been undergoing chemotherapy since then. So basically, pancreas tumor is a rare form of lung cancer and this tumor is located at the very top or apex of the right or left lung. And as this tumor grows, it can invade surrounding nerve, muscle, lymph node, connective tissue, upper rib, and also upper vertebrae. And this patient is also a die-hard smoker since 15 years old up until now. And for the family history was unremarkable. Next. Okay, let us look at the examination that have been done to this patient. On this slide, for the current glass and also refraction for this patient, basically there is no significant difference between current glasses and also refraction. And with this refraction, patient basically can achieve 6 for distant vision and also 5 for near vision. Next. Okay, as we look at this examination, as I highlight in the pupil reaction for the right eye, basically this patient have something need to be concerned of or abnormal for the right eye for the pupil reaction, which is miosis. I will show it in the picture later on. And this is slow to dilate, especially in the dark room for the right eye and normal for the left eye. Next. Okay, for the ocular health, this patient has mitosis on the right eye and I will show in the picture later on. And for the anterior and posterior segment are normal and other than this examination is unremarkable. Next. Okay, as you can see, this is the picture of this patient. As you can see at the right eye, this patient have a droopy eyelid on the right eye and the size of the pupil of the right eye is significantly reduced compared to the left eye. Okay, next. Next, we will go to the tentative diagnosis. So there are a few tentative diagnoses that we have ruled out in this PBL. So firstly is retinitis pigmentosa, and we rule this retinitis pigmentosa due to this patient complaint of difficulty in night vision. But then we cross this out. Next. Okay, due to next Retinitis pigmentosa usually is a genetic disease and the symptom usually start in the childhood. But then this patient just complain about the night vision difficulty and then the patient's age is also 45 years old. So we cancel this out, this tentative diagnosis. Next, we also put cataract as the tentative diagnosis. But then we cross this out. Next. Okay, next. Because from the anterior segment assessment, it shows that the patient has normal anterior assessment. Next, we also rule out. We also put the hypertensive retinopathy as one of the tentative diagnosis because this patient complained of night vision difficulty. So we expect that this patient have peripheral peripheral defect and it lead to the defect of the rod. But then we cancel this out. Next, because the posterior segment of this patient is normal and patient does not have hypertension. So next, we also put the trauma, one of the tentative diagnosis because this patient have a droopy eyelid. But then next, we cancel this out due to the no history of ocular trauma and also anterior segment of this patient is normal. Okay, next. Okay, next is nyctalopia. Nyctalopia is basically a night blindness that people cannot see well in night or in poor lighting condition. But for this patient, we cancel this out for nyctalopia because next, it usually related to the retinal problem. But this patient have a normal posterior assessment. So next, for the third nerve palsy, we does not cancel this out due to patients do have unequal pupil size between right and left eye. And the right eye, as we can see in the picture I showed before, the right eye pupil size is smaller than the left eye pupil size. Next is an isochoria. We also does not cross this out because the patient do have miosis on the right eye and normal pupil size on the left eye. And lastly, we put the Horner syndrome, one of the diagnosis, one of the tentative diagnosis because this patient do have ptosis, miosis, and also reduced sweating on the affected side. So these are all for the tentative diagnosis. Let us go to the final diagnosis. Okay, so for the final diagnosis, we conclude that this patient have Horner syndrome and the third palsy and anisocoria is the signs for the Horner syndrome and we include it as a final diagnosis. So that's all from me and the more for the explanation for Horner syndrome will be explained by my friend later on. So I will pass to the next presenter.
Okay, so now I am Ramis Mardia. So I will be explaining on the definition and the prevalence of the Horner syndrome. First, for the definition, Horner syndrome, which is also known as Horner-Burnett syndrome or ocular sympathetic palsy, it is a rare condition that occurs due to disruption of sympathetic nerve pathway in the side. Horner syndrome is Horner syndrome is categorized by a compilation of signs and symptoms. Signs and symptoms. One of the most common presentation or sign or symptom that present in the patients with Horner syndrome is partial ptosis or droopy eyelid and also miosis and also facial anhidrosis. Like this patient, Encik Ramli, he has all these three symptoms, which is a droopy eyelid, miosis, and also facial anhidrosis. Next. Okay, Horner syndrome is also resulted, it may be resulted from another medical condition such as stroke, tumor, or spinal cord injury, which is later my friend will explain on the, will be briefly explain on the what diseases or what medical problem that can cause Horner syndrome. And then in some cases, Horner syndrome is like idiopathic, which is we did not know what is the causes of the Horner syndrome. And then next, Okay, first, as I mentioned before, that Horner syndrome is resulted from the disruption of sympathetic pathway. First, I'll explain a little bit briefly on the sympathetic pathway of the eye. And then first, there are three stages of the pathway. First pathway is like the central pathway, which is it starts in the posterior hypothalamus and it goes down to the brain stem and further to the ciliospinal center of Bash of the spinal cord, which it is located between C8 and T2. And then that is the first pathway, which is central pathway. And then for the second, it is preganglionic system sympathetic fibers. This it started from the ciliospinal center, and then it formed a synapse at the superior cervical ganglion at the neck in the neck area. And then during its long course, it can one of the like it pathway is like one along the pathway along the pathway it also um, located at the uppermost area of the lung. And then next no okay then the third pathway, the third neurons for this pathway is postganglionic pathway. And then this neuron started from the superior cervical ganglion and follows the external carotid artery to innervate the sweat glands and also blood vessels of the face. And then the remaining fibers ascends along internal carotid artery in the carotid plexus to enter the cavernous sinus and then join the cranial nerve number 6 and then also enter the orbit area via superior orbital fissure and merge into long ciliary nerves and also short ciliary nerve. And then it innervates the eyelid and also innervates the muscle for the mydriasis. And then next, this is one of the pictures that I found on the internet, which shows that the condition of Horner syndrome. This picture is like on the right eye. Patient has right Horner syndrome, but Horner syndrome on the right eye, and then we can see that the right eye has meiosis, slightly or mitosis, and but you cannot see the facial anhydrosis. And then next, this illustration shows that it is simple, but it is full with information that say that Horner syndrome is a problem with sympathetic nerve supply to one side of the eye. And then next, now we'll proceed with the prevalence of the Horner syndrome. Next, there is in the worldwide, the incidence of Horner syndrome is 1 in 6,250. In worldwide, the patient in worldwide, 1 in 6,250 50 people that is born with Horner syndrome. And next, among Caucasian, the incidence of Horner syndrome is like 4.24 among per 100,000 per year, which is like it is there is someone that with Horner syndrome per year. And then next, in this study, the incidence of pediatric Horner syndrome, and this from the study shows that 1.42 per 100,000 patient is patient with Horner syndrome is pediatric, which is below 19 years old, which is like we can see that there is although the condition is rare, there is patient that have Horner syndrome. And then next, I think that's all from me. And then we'll proceed with the etiological problems or etiology of the Horner syndrome.
Okay. So I am Nurhayati and I will talk about the etiology. Okay, next. Okay, so we can see here the sympathetic pathway from the brain to the eyes, as Mardia has explained just now, which is the central neuron. Next. Okay, central neuron, preganglionic and postganglionic. Okay, so I will talk about the what can cause what happen in the certain neuron that interrupt the pathway, the sympathetic pathway. Okay, next. Okay, so for the center neuron, at the hypothalamus, brainstem, it can occur due to the stroke and tumor at the hypothalamus, also at the brainstem, and also at the brainstem there can be the demyelination, and of at the spinal cord, it can also happen due to the tumor, demyelination, and syringomyelia. Okay, so next is at the preganglionic neuron, or we can also see it as a second order neuron. Okay, this includes the lesion at the apical lung, like Mardia has said just now, the upper part. Okay, so it can happen due to the pancreas tumor, subclavian artery aneurysm, myointestinal mass, and also it can happen due to thyroid tumor. In this case, it is highly suspected that this patient has uh, an interruption at the preganglionic neuron due to she is having a pancreas tumor. Okay, next is the for the postganglionic neuron. Uh, at the cavernous sinus mass, they can have a tumor, thrombosis, pituitary tumor, and the carotid aneurysm, which can cause the lesions. And also at the internal carotid artery, there can be the dissection, the aneurysm, and thrombosis at there. And also there can be the lesion at the supracervical ganglion. Okay, so and also there is I will just talk about it. Uh, Horner syndrome can also be a congenital, which is it can be at the birth due to trauma, or it can also be due to idiopathic, no reason. Okay, next is the path- pathol- pathology. Okay, so the pathology, there is no exact pathology. So, but it is a combination of the sign. Okay, so I will talk about the sign, which is first, the patient has a partial ptosis. This is because the sympathetic pathway from the midbrain to the eye, there is a Mueller's muscle which is known as the superior tarsal muscle, and it helps to raise the upper eyelid and has a so the denervation of this muscle cause will cause ptosis, but it is milder than the oculomotor nerve palsy, which slash the levator palpebral superior cyst, because the superior tarsal muscle is responsible for keeping the upper eyelid in a raised position after the levator palpebral superior raises it. So this can explain why the patient has partial ptosis and not as much as when someone has oculomotor nerve palsy. Okay, next is pupil constriction or meiosis. This is because the sympathetic nerve is responsible for the pupil dilation, which is mydriasis. So when it is interrupted or disrupted, it will cause the constriction of the pupil, which is meiosis. Okay, next. Accelerator and hydrosis. We can see from the trigger that the patient complained that he also noticed that he has reduced sweating, especially on the right side under same duration. This is because he, and the sweat glands produces sweat in the sympathetic response, and uh, the anhydrosis. This is for the first order neuron. The lesion affects the ipsilateral side of the body. However, for the second order neuron, it will affect the ipsilateral face. So we it because the sympathetic pathway is interrupted, it will reduce the sweating produced on the affected side. Okay, next. Okay, next is the high iris heterochromia. It usually happens in the children younger than 2 years, and is a congenital form of the syndrome. This is due to when a patient has Horner syndrome, they will tend to have a reduced melanin on the affected side. It will lead to the iris heterochromia. Okay. Okay, so this is the reference. Okay, that's all from me.
Okay, so now I will explain on the sign and symptom of Horner syndrome. Actually, the sign and symptom has been explained by Hayati, but I will explain more on the neurological sign that can be seen in Horner syndrome. But I also will explain on the sign of the Horner syndrome on the optometry part. So first of all, these are the three main symptoms that can be seen for the patient that have Horner syndrome, which is ptosis, eyes hypochondria on the affected sides, and facial anhydrosis, which is reduce of sweating on the facial on the affected side of the eye. And second is a delay dilation pupil due to the effect of the denervation of the systemic nerve that function to constrict the pupil, and smaller ipsilateral pupil on the affected side of the eyes that have Horner syndrome, and also increase of AA in ipsilateral side. So for the increase of amplitude of accommodation on the patient that have Horner syndrome, actually in all study that have been read, the the reason of the increase of AA is not properly explained. However, I can conclude that the increase of AA on patient with Horner syndrome due to the disruption of the sympathetic nervous system that cause the parasympathetic nervous system to be inhibited and cause the constriction of the pupil. And this is the less common sign that can be seen in Horner syndrome, which this is actually the neurological sign. The first one is the vertigo, which is the sensations of the environment feel like spinning. So patient with Horner syndrome may feel like they lost balance due to the disruptions of the nerve. And secondly is dyspragia, which is the swallowing difficulty. The third one is the nystagmus, which is the repetitive movement of the eye, the uncontrolled repetitive movement. And the fourth one is facial weakness due to the due to the denervations of the nervous system. And then I will explain on the clinical examination. For the clinical examination, I will explain on the eye examinations and health examinations. So for the eye examination, the most important examination that need to be done is pupil reaction to the light and accommodation. Because as you can see before this, the signs of the Horner syndrome that we can see, the most significant sign is the uneven pupil reaction between two eyes. And second, we also need to measure the pupil in the bright ending. so that we can see how many significant difference between two eyes to for us to diagnose Horner syndrome. And second, and the third one is the examination of the upper eyelid, because patient with Horner syndrome usually comes with ptosis. We can also do the fatigability test, which is the test to test the ptosis. How this test be done is by testing the shoulder abduction before and after unitary repeating arm movement. Second is the ocular motor test. So because this patient have ptosis, so we need to examine the motor system, because we want to see whether the muscle is affected or not. Second is a visual acuity test, because this patient have unilateral pupil reactions. So we afraid that because of this condition, the visual acuity will be affected also. And second is the color vision. Color vision need to be done because this disease affected on the nervous system. So uh, it might also um, it might also affect the color vision. So we need to do the color vision as part of the eye examination to diagnose Horner syndrome. And next is the visual field test. Visual field test need to be done because this patient have ptosis. So we afraid that because of the ptosis, the visual field will also be affected. And for the cilium examination, it needs to be done because this patient have an equal pupil size. So we need to do cilium examination to observe more on the pupil size. So we can see if there is any other abnormality on the pupil. And the last one is the pupil dynamic test, because this patient have for the Horner syndrome patient have delayed dilations of pupil on the affected cells. So pupil dynamic test is one of the best tests that can be done to test or to measure the movement of the pupil when there is light stimulations. So for the next examination that need to be done for patient that have Horner syndrome is health examination. For the health examination, I divide this health examination into three parts, which is lab test, imaging, and pharmacological test. So for the lab test, because Horner syndrome usually happen due to some condition or some disease. So lab test is one of the most important tests need to be done. So the first lab test that need to be done is CBC, which is complete blood count, ESR, erythrocyte sedimentation rate, and serum chemistry panel. So usually patient that has been suspected with Horner syndrome will lab test. Second is urine and blood culture. For the urine and blood culture is will usually been tested by the doctor when there is suspected of infection for the patient, and the testing for the neurosyphilis, HIV, and thyroid eye disease usually need to be done when we suspect that the patient have these kinds of disease such as HIV, neurosyphilis, and thyroid eye disease during the interview. And the fourth one is the urine testing. Urine testing need to be done if the patient is suspected with neuroblastoma. And for the PPD, purified protein derivation, we usually need to done this test when the patient is suspected with tuberculosis, or we call TB. Second is the imaging test, which is chest ray, computed tomography, CT, and MRI. So for the chest X-ray, we usually order this test when the patient have suspected pulmonary meningoencephalocity, and for the CT and MRI, usually we doctor will order this test when patient has a possible to get the stroke. So for the pharmacological test, I will only explain this generally on the name of the test, and for the further and detailed information will be explained on the management part by Badiou Zaman. So for pharmacological test, so there is a few drug or agents that can be used to diagnose Horner syndrome. So the first test is topical cocaine test, where we use cocaine as agent. Second is topical hydroxymethamine test. The third one is topical aprocholene test. And we also use other agents like polydrins, adrenaline, and phenylephrine. So all of these tests, we don't need to undergo all of these tests. Uh, we will only do several tests based on the condition of the patient. And actually, these tests also have advantage and disadvantage. So to undergo these tests, the doctors will choose the right test for each patient. Not all patients will undergo the same test. So that's all from me.
All right, let's go to the managements. We as the optometrists actually do not have any specific treatment for the Horner syndrome patient. Please next. Okay. No specific treatment that is available for the moment for the patient. We can just refer the patient to the ophthalmologist, and the ophthalmologist also do not have the specific treatment for the patient, but they can just conduct further assessment or several assessment in order to identify or to diagnose the patient has the Horner syndrome. Next. All right, first we have topical cocaine test. So the cocaine that we use in this test is actually act as the indirect sympathomimetic in order to inhibit the reuptake of norepinephrine from the synaptic cleft. So how much they use for the test is ranging from 2% to 10%. That will be instilled on both eyes. So the evaluation in order to elevate it or to take the result is at least for 30 minutes or more in order to identify the optimum response from the eye after the installation. And then the affected eye is actually, we can observe that it is dilate poorly compared to the normal one. So the patient that has the sign of anisocoria of 0.8 millimeter or more can be considered as Horner syndrome, having Horner syndrome. Next. However, this test has several disadvantages because first, the test does not help in identifying the level of the lesion. This test is only just can be detect the presence of the Horner syndrome. Then the price for this test is very high because the dispensing of the cocaine, the production of this chemical is very difficult and causing much prices in the production. And then it is time consuming, yes, because it uses 30 minutes or more in order to identify whether the patient has the Horner syndrome or not. And then the test yielding ambiguous results. It can be vary, can be anything that it can come out. And then the metabolite of cocaine can be detected in urine. So if the patient must undergo urine test for a short term, it may cause that the result can be positive or the drug test can be positive using the urine. Next. Okay, we have topical hydroxyamphetamine test. So this test is very helpful in order to identify the localization of the lesion. So hydroxyamphetamine actually stimulate the release of stored norepinephrine from the postganglionic terminals into the synapse. So how much they want to use, the ophthalmologist want to use, is 1% hydroxyamphetamine solution with 2 drops instilled into both eyes. So how they want to detect the Horner syndrome eye. The affected eye will not dilate as well as normal eye. However, if the patient has the case of intact postganglionic fibers, the affected pupil will dilate to an equal or greater extent. Next, we see the disadvantages of this test is first, it not being able to perform on the same day. So it cannot be rely on the first day. It can be, as I said before, is very various of results. So we should not rely on the first day or one day only. And it can be false negative result because we can, as I mentioned before, it is very various. Result can be taken for a day. Next. Okay, next we have the topical apraclonidine test. So this test is very good at sensitivity and overall practicality. The apraclonidine acts as weak alpha-1 agonist and strong alpha-2 agonist. So it is categorized as an ocular hypotensive agent. So the upregulation of alpha-1 receptors in Horner syndrome will translate the into exaggerated response of the iris dilators and to agonist agent like apraclonidine. So the patient that has Horner syndrome actually will greatly respond to the apraclonidine test instead of patient that does not have the Horner syndrome. Next. So how much they want to use, ophthalmologists want to use to detect the patient is in about 0.5 to 1% solution will be instilled in both eyes. So how they want to be detected? The affected eye will show mydriasis while the normal eye is prominently insensitive. As I said before, the patient that be instilled with this test, this solution will cause Horner syndrome eye will cause very active, very active mydriasis. And then consequent installation of the solution result in an evident reversal of anisocoria. So it can be that the affected pupil will dilate and the normal pupil will be constrained. So this can be detected where the eye are having Horner syndrome. So this is because that the stronger alpha-2 agonist activity compared to the weaker alpha-1 agonist activity of apraclonidine. All right, next. This test has several disadvantages, including false negative result in acute cases. So if the patient has severity is very low, the mild, it can be false negative. It can be like normal or does not have any Horner syndrome. And then there is systematic side effects in pediatric population. It is not suitable for the children. And the inability to localize the lesion. We do not identify where the lesion is happening. And then the relatively long half-life of the drug. So the drug will be circulate in the body in a long time. It cannot be like hours, it can be days, and it can take much time for the liver to remove the drug from the body. Next. There are several agents that ophthalmologists can identify Horner syndrome by these agents, including first, pholedrine. It is roughly half as potent as hydroxyamphetamine and shown comparable result, but due to limited availability has been restricted. So there is likely have the same result from the hydroxyamphetamine. However, the production or the drug is like very limited and been restricted to use it. And then the adrenaline, it is a direct acting sympathomimetic, and also there's proposal to use the adrenaline. However, it has poor penetration through the cornea and can be sensitivity to drug is very various. It can be anything that happened to the eye. And then lastly, we have phenylephrine. It is a selective alpha-1 agonist and also has been proposed. However, it suffers from the poor penetration, same as the adrenaline, poor penetration to the cornea, and the result can be various, depending on the degree of denervation. Can, like, if it is mild, it hardly to detect, while the severe can, yes, it can be various too. Next. Okay, I will proceed to the prognosis. Next. Actually, generally, Horner syndrome likely will not be worsened at the moment. And like the sign of anisocoria, it does not becoming worse. And instead, half of the cases can be resolved of half of the cases can resolve of the symptom. Next, the sign of the ptosis in about third cases improves spontaneously or completely resolved in 7.9 years, which is the mean of the paper of the research after the diagnosis. And then lastly, the sign of oculosympathetic. So the unilateral eye that affected only one eye, there is no sign and there is no paper that show that does not have developed no development of into to bilateral. Next. All right, for the conclusion, from this case, it is important to understand the patient's complaint, to identify the tentative diagnosis that we must rule out, and then to understand the nature of the condition. So in these cases, that we must understand the nature of Horner syndrome. So if we cannot do anything or we cannot treat them as we available in our clinic, thus we may refer to the expertise like ophthalmologists or several expert that can be handle this case. So the identification of the Horner syndrome is can lead to us or to the expertise to manage the best management, the best treatment for the patient, especially at the early age, at the early stage. So next, is next. These are the references that we taken from the information that we taken from. So that's all from us. Thank you.